Mhm. Alrighty, hopefully you guys can see that okay. Okay. Can you see that okay? Perfect. We'll get started here. Okay, cerebral and endocrine dysfunction. This was week 7. So this exam will be 7, 8, and 9. Growth hormone is administered by what route? Sub-Q injection, which is red, orally, which is blue, IV, which is yellow, or IM, which is green. How is growth hormone administered? So sub-Q actually is growth hormone. It just goes right under the skin. It doesn't have to go into a muscle like our other, immunizations. Most immunizations. Okay. If you guys have questions on stuff too, you can have me pause. Highest priority for a patient diagnosed with SIADH, so syndrome of inappropriate antidiuretic hormone. Decreased deep tendon reflex, which is red, increased temperature, 100.9, which is blue, EKG changes, which is yellow, or INO, which is green. It's going to be the thing that you're most concerned about. Okay, remember, SIADH is you're not getting rid of your fluid. You're holding on to that fluid. Okay? Because you're not producing enough antidiuretic hormone. Okay? Good. Okay, which of the following are signs of SIADH? Red is decreased urinary output. Blue is decreased urinary specific gravity. Yellow is increased urine glucose. Green is increased urine output. Yes, you're holding onto that fluid. You can't urinate like you appropriately would because you're not making enough antidiuretic hormone.
Professor, wouldn't that one be associated with Cushing's syndrome or disease?
Yes. Yep.
Some
Doesn't
where they're like really bloated or look
puffy.
like
Yep.
puffy.
Yep. They're going to have fluid overload because they can't get rid of the fluid because they're not making enough of the antidiuretic hormone. Okay. They're holding on to it instead of getting rid of it. Doesn't mean officially that because people have Cushing's, they're going to also have SIADH, but you do see that more often with Cushing's. Good. What is important to cover when teaching the family about PTU? It's used for hypothyroidism, leukopenia, so they're at risk for fever or sore throat, increased blood sugars, or take at bedtime. What do you teach them about PTU? Okay, so PTU causes leukopenia. Okay, so it kills off those white blood cells. So they're more at risk for infection. Jasmine, if you want to join the Kahoot.it, and then the game pin down there is at the bottom, so you can join us. Okay, so your concern with kids taking PTU would be infection. Okay, so teaching parents about the risk of infection. Good. Okay, multiple select. An initial sign of diabetes insipidus is polyphagia, which is red, polydipsia, which is blue, polyuria, which is yellow, or hyperglycemia, which is green. Yes, polydipsia and polyuria. Those are your initial signs, okay? And diabetes insipidus is not, the classic diabetes that you think about. It's not diabetes mellitus, okay? Okay, another multiple select. What are the clinical manifestations of juvenile hypothyroidism? Dry skin, sparse hair, which is red, constipation, which is blue, weight loss, which is yellow, green, which is decreased growth, which is green. Constipation, sparse hair, and dry skin, and decreased growth. And it wouldn't be weight loss, it would be weight gain. Yep. So they're not growing in height with hypothyroidism, but weight gain is pretty common too. So if a kiddo comes in and they've had weight gain, their hair's kind of maybe falling out, or they haven't had much hair growth, and you check their height and they've lost inches, or they've not grown at all in the last year, then you would be pretty suspicious of hypothyroidism. Okay. Okay, child had a simple febrile seizure. What education would you provide to the parents? Proper usage of anti-epileptic medications, which is red. Education regarding epilepsy, which is blue. Safety precautions to take if another febrile seizure occurs, which is yellow. Long-term deficits associated with simple febrile seizures. Yes, safety precautions, because do febrile seizures, like once you have them, it means you're going to have a febrile seizure all the time? It's usually just a one-time thing, right? Usually. There are about 20% that maybe will have other febrile seizures if they're sick again, but it's not usually a diagnosis of epilepsy, okay, or a seizure disorder. So just teaching them safety precautions in case. So what would some safety precautions look like? What would you teach parents?
Like to turn them to the side, if document how long the seizure occurs,
Yes.
if they remember anything that happens afterwards,
Uh-huh.
to make sure there's like nothing in the mouth,
Uh-huh.
like
Cut through
supporting the head.
Yep. Or like removing things, sharp
Yeah, like
objects, or
anything around
that
the
they could hit.
area
Yep.
that could cause any type of injury to them, you
Yep.
want to remove it.
Yep. 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 Good. What about like breathing after a seizure? What should, if you have a patient that has a known seizure disorder in the hospital, what should be in the room?
Like
Suction.
something for
Suction.
like suction.
Suction should be set up. If you have a child, well, a respiratory child, but especially a kiddo with seizures, you should always have suction already set up and oxygen set up too. Because it's not necessarily with febrile seizures, but it's not uncommon if you have a seizure disorder, for them to be kind of hypoxic when they're postictal, right? So that period where they're kind of out of it and don't really remember and they're really sleepy. The other thing is pads on the side rails. Okay. And then your individual hospitals, like say you worked in a peds unit in a hospital somewhere, they may have another slightly different protocol, but
Wouldn't they normally have the beds lowered too?
yep,
If so, like when they have to see the seizure, they don't like fall over. It's like
yep,
at a level.
yep. Or sometimes they have pads, like padded floors on both sides of the bed too. Yep. Good. Okay, what type of seizure is when the body is jerking, foaming at the mouth, and the child is rendered unconscious? Absent seizure, atonic seizure, tonic-clonic seizure, or psychoseizure? Tonic-clonic. Yep. So that's jerking and then kind of lessen tension, jerk, lessen tension, jerk. Okay. Good. And they for sure will have a post-ictal period after tonic-clonic seizures. What notable sign may indicate increased intracranial pressure in an infant? Overflow voiding, which is red, bulging fontanelle when crying, which is blue, high-pitched crying, which is yellow, minimal lower extremity movement, which is green. High-pitched, shrill cry. Okay. The bulging fontanelle when crying, that's not necessarily an uncommon finding. When babies are crying and upset, you will see their fontanelle kind of be bulged. But if they're calm and their fontanelle's bulging, then that would be a sign of increased intracranial pressure as well. So bulging fontanelle when crying is kind of a expected finding. But high-pitched cry is pretty classic of a kiddo with increased intracranial pressure, especially if you can't get them calmed down. Okay. Good. All of the following are increased intracranial pressure except, so fluid overload, which is red, coughing, which is blue, tachycardia, which is yellow, suctioning, which is green. All of the following increase intracranial pressure except, yes, tachycardia does not increase your intracranial pressure. But if you're fluid overloaded, you're going to have more fluid just generally about the body, which is also going to increase your cranial pressure. Okay. Coughing. Think about when you cough. When you're sick and you cough, your head feels like so full, right? You instantly get a headache. So that's a sign right there that you're having increased intracranial pressure. And then suctioning as well. When you're suctioning, it will increase your intracranial pressure for a period of time. Okay. Questions about that one? Okay. What findings can you alert you to a head injury that has gotten worse? Decreasing restlessness, change in orientation, headache improving, or easy to arouse? Change in orientation, yes. So if you're monitoring somebody with a head injury and all of a sudden they were talking to you earlier and maybe everything didn't quite make sense what they were saying, but you could understand most of it, and then they're not talking to you at all and not responding to anything but, a sternal rub, that would very much tell you that a head injury is getting worse. Okay, so change in orientation. Good. Multiple select. What does it mean when you see a fixed and dilated pupil after a head injury? The brain is compensating for the swelling, which is red. The pupil remains fixed for greater than 5 minutes. It means brainstem damage, which is blue. This is a neurological emergency, which is yellow. Or the brain is responding, which is green. Fixed and dilated pupils. Okay. So if they are fixed for longer than 5 minutes, that's usually brainstem involvement or damage is involved in the head injury, okay? And your brainstem controls your heart, your lungs, you know, your will to live kind of, or your basic functioning of living. So, um, and then of course it's a neurological emergency if somebody's pupils are fixed and dilated when you know that they've had a head injury. Okay. What medication may be used for a child with cerebral edema due to a fall? Furosemide, which is red, phenobarbital, which is blue, mannitol, which is yellow, or phenoltonin, which is green. Mannitol. Okay. Mannitol is going to be your go-to to help with ICP. So increase intracranial pressure, cerebral edema, very similar things, right? They kind of can be used interchangeably. And mannitol would be the medication that you use for that. Good. Febrile seizures usually occur in patients younger than 3 months of age, which is red, patients between 6 months and 6 years of age, which is blue, teenagers between 13 and 18 years, or adults who are older than 25. Yep, good. Between 6 months and 6 years is the most common time for febrile seizures. Okay, good. Childhood hypopituitarism results in which condition? Gigantism, pituitary dwarfism, acne, or achondroplastic dwarfism? Yes, pituitary dwarfism. That happens with hypopituitarism. So these kids are going to, what's going to happen with their growth curve?
Like they won't grow.
Yeah.
They'll stay small.
Yep.
Those
Yeah,
are
or they
theory.
might start maybe a little elevated, like they might start on their growth curve, right, at like 2% or something.
But then it'll like
They
stop at a
keep
certain
dropping.
point, right?
Yep, they keep dropping off of their growth curve. So like maybe they were on the chart, right? And then they'll just keep falling down off the chart. Okay, good. How would you describe precocious puberty? Reaching puberty early, breast development at age 6, menstruation at age 7, growth of bones and muscles. Yeah, so precocious puberty is reaching puberty early. Okay, so early puberty, precocious. So earlier than you should. Okay, good. Multiple select. What lab values are important to monitor for a child with congenital hypothyroidism? Thyroxine or T4, growth hormones, TSH, or cortisol. Okay, T4 or thyroxine, TSH. Also, if T3 was in here, that would be important too. As far as hypothyroidism, for monitoring for that, you don't necessarily care about cortisol or your growth hormones, right? Because even if we give these kids growth hormones, if their TSH and their T4 and T3 aren't working like they should, they're not going to grow like they should. Okay. Good. How can you monitor a child with hypo or hyperthyroidism? Record height and weight, strict measuring of weight monthly, measuring performance in school, monitoring food intake. Yes. Height and weight. Are they growing the way that they need to be? And that's with hyperthyroidism and hypothyroidism both. Good. What acid-base alteration would you suspect in a diabetic child with Kussmaul's respirations? Respiratory acidosis, metabolic acidosis, respiratory alkalosis, or metabolic alkalosis? Respiratory alkalosis, because they're breathing off the CO2. So that's making their body more alkaline with their breathing. Okay. So they're breathing off the CO2, which is causing them to be more alkalic or basic, right? Good. Okay, multiple select. What would a child with Cushing syndrome look like? Kind of already talked about this a little bit. Moon face, red ruddy cheeks, more than usual hair growth, or fat in the trunk and face. This was a multiple select. Yes, all of those things. Moon face, so they're gonna look like really puffy, very, very circular face, okay? They're gonna usually have red, ruddy looking cheeks. They're gonna have more than normal hair growth, and then they're gonna carry their fat in not only their face, right, their moon face, but also their abdominal trunk is going to be more obese. Okay. Good. Multiple select. You walk into a child's room with a fever of 104.6 and you see them having a seizure. What can you do? Check the bed for objects that can hurt them. Side rails up and pad them if possible. Turn the child to their side. Give a cold water bed bath. Yes, so check for sharp objects or things that they could get hurt on. Put the side rails up and put a pad on the side rails so that way they're not hitting their head or something into the pad. Turn them on their side. What kind of bed bath could you try to give them when they're done with their seizure to help with their fever? Not cold. Tepid, like room temperature. It's not cold water, but you could try to, help with their fever a little bit. Give them kind of a lukewarm bed bath. Okay. Good. Okay, an autoimmune disease of the thyroid gland. Goiter, Hashimoto's disease, thyroiditis, or parathyroidism. Hashimoto's thyroiditis or Hashimoto's disease is the autoimmune form of the thyroid gland. Good. Addison's disease is decreased secretion of cortisol, decreased secretion of cortisol and aldosterone, increased secretion of cortisol, or increased secretion of cortisol and aldosterone. Yes, decreased secretion of cortisol and aldosterone is Addison's disease. Okay. Good. All right, multiple select. Ventricular, oh my goodness, VC shunt. Okay, it's used with hydrocephalus. Do not bump the shunt is what it should say, not pump. Used for epidermal hemorrhage or measure the head circumference every shift. Yes, for a BP shunt, it's used for hydrocephalus. You shouldn't try not to bump the shunt, right? So there'll be a portion in the head, and then also the other portion will be in the peritoneal area, so in the abdomen. Okay. So try not to hit the shunt, and then you're going to be measuring the head circumference every shift. What happens if you measure the head circumference and it's getting higher? The number's getting higher.
And then the VP shunt isn't working properly, so it's not excreting the amount of
Fluid.
fluid that it's supposed to excrete to the body.
Yep, exactly. So call your provider right away. Okay, common sign of Graves' disease includes blank or protrusion of the eyes, exophthalmos, exprotrosis, ptosis, my goodness, ophthalmia, or goiter. Exophthalmos, that's that protrusion of the eyes, okay? So like in this picture, you can see how her eyes look like really protruded. That a lot of times you can tell that somebody has Graves' disease from just that alone, the exophthalmos, okay? Good. Okay, multiple select. Hypoparathyroidism has the symptoms of tetanic muscle contraction and muscle weakness, elevated vitamin D levels, tetany, or low calcium levels. Hypoparathyroidism. Muscle weakness, tetany, which means they no longer, so like it's going to be tense muscle contraction. Your muscles aren't going to work like they should. And then you're going to have low calcium levels. Okay. Good. Multiple select. What are signs of hyperparathyroidism? Nausea, vomiting, paresthesias in the extremities, confusion, hypocalcemia. Okay, so nausea, vomiting, paresthesias, so that numbness and tingling, that's what a paresthesia is, remember, and confusion. We would have hypercalcemia with hyperparathyroidism. Okay, not hypocalcemia. Okay, good. What does parathyroid hormone do? Regulation of calcium levels in the blood, regulates urinary output, growth hormone, sex assignment. Okay, it regulates your calcium levels in the blood. Okay, good. Parathyroid hormone helps regulate your calcium. Which of the following may be a cause of adrenal crisis or Addisonian crisis? Fluid overload, abrupt withdrawal from steroids, hyperglycemia, or extreme hypertension. So an abrupt withdrawal of steroids. So if you're on glucocorticoids or steroids, so prednisone or something like that, and you've been on them for more than like a week, and you just stop them and you don't wean off of them, so titrate down, then you will go into an adrenal crisis. Okay. That's why if people
So
are
when you mean wean down, Professor, you mean like lowering the doses that you
titration.
originally started with?
Yep, yep. So yeah, usually if kids are gonna be on steroids, say they had, oh, I don't know, a really bad asthma infection and they needed steroids for longer than just the 3 to 4 or 5 days, then they'll start at a higher dose, right? And then you titrate it, usually decrease by a few milligrams a week. So that way they don't go into adrenal crisis. Because if you have them do steroids higher dose for a week and you don't wean them off, then they're at risk
So
for
like you started like with like, I don't know,
60
100
milligrams.
milligrams, you would like go to like maybe 80 or like then
Yep.
70. Oh, okay.
Yep. Exactly. Good. Multiple select. Cardinal signs of diabetes insipidus. Polyphagia, polyuria, polydipsia, decreased urinary output. Polyuria and polydipsia. Good. Whoops. Okay, another multiple select. Congenital adrenal hypoplasia. Parent teaching should include the child is infertile, requires gender assignment, cortisol and aldosterone replacements, or no genetic testing is needed. So if a kiddo is born with congenital adrenal hypoplasia, what sort of education would? Yep, the kiddo is going to be infertile. Okay. They're going to require gender assignment because they're going to have both parts, right? Because of their congenital adrenal hypoplasia or portions kind of both parts. Okay. And then they'll also need cortisol and aldosterone replacements for their lifetime.
That would be like very rare for a child to have, right, Professor? 'Cause
Very,
it's
very
like
rare.
one of those one in a whatever type of
Yep.
things.
Yep. Like I have been in nursing since 2013 now, and I've never seen a kiddo with congenital adrenal hypoplasia or a history of it even. So it's very rare. Okay. Good. What causes type 1 diabetes? Destruction of beta cells by autoimmune process, too much candy, a progressive disorder with combination of insulin resistance, impaired fasting glucose, and impaired glucose tolerance. Yes, so it's a destruction of the beta cells. Which, do you guys remember reading about longer hands cells? Yep, so those are your beta cells with your pancreas, okay? So your longer hand cells or your beta cells are destroyed, okay? They do not work so your insulin does not work. So type 1 diabetics have to have insulin lifelong for right now, okay? Which statement about pheochromocytoma is correct? It is usually malignant. It is a catecholamine producing tumor. It is only found in the adrenal medulla, or it is normally manifested by hypotension. So it's a catecholamine producing tumor. Okay. Pheochromocytoma. Good. Multiple select. Which action should the nurse implement in the care of a patient with pheochromocytoma? Monitoring glucoseuria, monitor for elevated heart rate, monitoring for hypertension, monitoring for sudden weight gain. So monitoring for elevated heart rate and elevated hypertension because of your catecholamine storm that you're going to get with you having a tumor that's dumping catecholamines. Remember, catecholamines make our heart rate race and increase our blood pressure. Okay. Those are the two most common things that catecholamines do. Good. Multiple select. Nursing care for the unconscious child includes neural signs every 2 hours, pain control, vital signs with a temperature every 2 to 4 hours, monitoring strict INO. This was multiple select. Neural signs every 2. Oh, excuse me. Vital signs with a temperature every 2 to 4 hours, and then strict INO with these unconscious kiddos. Okay. Pain controls can still be a part of it if they're having signs of pain based off of their vital signs and things too. Okay. What might you suspect in a child if they're feeling jittery, sweaty, and dizzy? Child is having a seizure, the child is in pain, hypoglycemia, or the child has a fever. Hypoglycemia. Okay. Good. Signs of DKA are fruity breath, excessive hyperglycemia, ketonuria, or all of the above. All of the above. Yep. So fruity breath, high blood glucose, and ketones in their urine. Those are signs of your diet, of your DKA. Okay, good. Multiple select. An adolescent with a BMI above 95th percentile has been urinating a lot. What test could you anticipate? UA, pregnancy test, hemoglobin A1C, electrolytes. Oh, excuse me, my goodness. UA and a hemoglobin A1C. And you want to see what their blood sugars have been, over that 3-month period. You're going to use the hemoglobin A1C. And that's going to kind of tell you about their average over that time period. And then your UA is good because if they're urinating a lot and you're concerned that they have diabetes, they might have ketones in their urine, or they might have high sugar in their urine. Okay. Or you want to also make sure that they don't have an infection that's causing them to urinate frequently. Good. DKA is caused by lack of insulin leading to the use of other fuels for energy, overdose of insulin leading to a release of ketones. Ketones are poisonous chemicals which can build up, or most common in type 1 diabetes mellitus. Yes, a lack of insulin leading to the use of other fuels for energy. So then that's where you get the acidosis. Okay. Good. Another multiple select. Child is admitted with a blood sugar greater than 600 large ketones in their urine. What's your priority intervention? I saw your guys' faces. You're like, oh crap. So give regular insulin sub-Q, an IV bolus of normal saline, titrate an insulin drip, or replace electrolytes. What's your priority? Fluids and insulin drip, okay? Sub-Q insulin in these kids, if their blood sugar is over 600, is not going to cut it, okay? And you can't worry
Because
about their
you would like need something to act faster to get it back to normal levels, right?
Yeah, and also to flush the ketones and the acidosis piece out too. So the fluids kind of address the acidotic piece along with the insulin. You don't want to worry about electrolytes in a kiddo who's in DKA because their electrolytes are already going to be all over the place. You have to manage their diabetes first. Okay, so you have to address the hyperglycemia first. Okay, good. Diabetic child complains of feeling jittery. Their blood sugar is 45. What is the best treatment for the child? Novolog insulin, drinking a cup of orange juice, having the child rest, or decrease the next dosage of insulin. Good. Yep, have them drink some orange juice to bump their sugar back up. Good. Your patient has experienced a head injury. What would most concern you? No BM in 3 days, decrease urinary output, dry skin on the lower extremities, or a heart rate of 88. Decrease urinary output would concern you the most, because if they're getting fluids and things, but they're not urinating, what's going to happen? They already have a head injury.
Fluid overload.
Yes, so their increased intracranial pressure is going to go up, correct? Good. Okay, multiple select. How do you detect DKA? Child has elevated blood sugars, ketones are present in the urine, dehydration, or 4+ glucose in the urine. Yep, so elevated blood glucose, ketones in the urine, and +4 glucose in the urine. So they're going to have glucose in their urine, they're going to have ketones in their urine, and they're going to have high blood sugars. Okay. Good. Now, if they stay like that for a while, they're going to become dehydrated. Okay. If they stay acidotic too long. Good. All right, multiple select. What would alert you that a child's head injury is deteriorating? The child becomes confused, difficult to arouse, becomes restless, or the child's complaining of headache getting worse. And this was a multiple select. So all of those. Kids becoming restless is almost always a sign that there's more pressure going on in their brain as when they've had a head injury, okay? So if kids start, they start thrashing around on the bed, they're becoming more confused, they're harder to wake up. So those are kind of all signs of or changes in orientation, okay? Or levels of consciousness changes, okay? And then, of course, if their headache's getting worse, they already have a head injury, you're always concerned about that cranial pressure increasing. Okay, good. Child has been diagnosed with bacterial meningitis. What is the nursing priority of care? Strict INO, administering antibiotics as ordered, elevating the head of the bed at 30 degrees only, or administering pain medication. Yes, antibiotics, because it's bacterial, so it needs antibiotics. If it was viral meningitis, then your treatment would be slightly different. Okay, but bacterial meningitis, the most important thing is your antibiotics. Okay, good. What is the primary cause associated with submersion? Primary cause of injury associated with submersion: pneumonia, hyperthermia, increased intracranial pressure, or hypoxia. Hypoxia. Okay. So you're concerned about hypoxia with submersion. Okay. Last one, multiple select. Which CSF lab result correlates with bacterial meningitis diagnosis? Decreased red blood cells, elevated protein, low glucose, decreased white blood cells. Elevated protein and low glucose in your CSF is going to be suggestive of bacterial meningitis. What do you think your white blood cells would be in that sample? Because it's bacterial.
Increased.
Going to be increased because those white blood cells, they're the first ones to fight whatever's going on, right? So if you have a bacterial infection, they're going to be high because they're going to be going
Because
into
they're
that
trying to
CSF
fight off the bacterial
infection.
infection.
Yes. Yes. So you're going to have high white blood cells, not low. Okay. Good. All right. There's that one. Let's pause my share. Do you want to do week 8 or week 9? We've got about 10 minutes left. 9? 9? Okay. Okay, come on, computer. Alrighty, I'm going to share my screen again here. Should pop up here for us in just a second. Still loading, so it's slowly going to pop up for us. Okay. So week 9 is musculoskeletal and neuromuscular. Okay. Go ahead and hop on this one. We'll get started. Perfect. We'll get started here and we'll do a few of these for the last few minutes. Okay, multiple select. What is the priority for a nurse to assess following a CAST application? Pulses, movement, pain, sensation. So all four of those things. After a cast is put on, you want to make sure that they can wiggle their toes. If you can reach their pulses, like post-tibial pulse, so back behind their ankle bone, or the pedis pulse, dorsalis pedis, or if it's their arm, check their radial pulse. You're going to be able to check their pulses. You want to assess that they can feel pain or, sensation touching, and that they're not having extreme pain after having a cast placed. Okay, good. Multiple select. Patient teaching for a child with a fractured bone that has had a new cast applied. Use cool air dryer for itching. Use a hanger to itch inside the cast. Do not use powder or lotion in the cast. Child may swim once the cast has dried. Okay, so cool hair dryer. So a hair dryer on the cool setting, you can kind of blow under the cast. That can kind of help with some itching. And then making sure you're not using powder or lotion inside the cast. Okay, because that causes skin breakdown potentially. Okay, what should the nurse monitor after soft tissue injury? Vital signs frequently, neurovascular checks as ordered, oxygen levels if ordered, or eye nose. Yes, neurovascular checks. You want to make sure that they still have pulses, they're not pale, they can feel you touch, they're not having paresthesia, so numbness, tingling, all of that sort of thing. Pain is involved in your neuromuscular check or neurovascular checks too. Okay, good. Fracture that penetrates the skin is called simple, green stick, compound, buckle. Compound fracture. That's where it's a fracture through the skin. Compound fracture. Good. Multiple select. Bryan's traction. So used for a child less than 30 pounds. Hips are elevated and the legs at a right angle. Skin traction for developmental dysplasia of the hip, or check for skin breakdown. All of those things. Okay, so it's used for kids 30 pounds or less for developmental dislocated hip or hip dysplasia. Okay, and the hips are slightly elevated and the legs are at right angles. And then just like with any form of traction, you're gonna have scheduled skin checks. Okay, because you want to make sure that there's not skin breakdown happening where that traction is attached. Okay. What is the priority nursing care of a child with a compound fracture? IV antibiotics, neurovascular checks, pain medication, or hydration? So compound fractures, you're really concerned about an infection getting into that bone. Okay, so IV antibiotics is going to be what you would be prioritizing giving that kiddo. Okay, because of the fact that it's penetrating through the skin. What is priority nursing care for a child who fell off a second floor balcony? Monitor vital signs, neuro checks, strict immobilization of the spine, monitor INO. Good. Immobilization of the spine and the neck. Okay. They fell from a second floor balcony. That's a pretty fall that was far from the ground. Okay. So, it would be really important to do immobilization of their neck and their spine. So C color. Okay. Good. Principles of managing soft tissue injury include ACE wrap and taking to a provider, rest, ice, compression, elevation, elevate and place a heat pack, ice bags, and Tylenol. See, we need to correct our spelling in acetaminophen. Rice. Remember rice with soft tissue injuries. Rice is going to be your thing that you do. So rest, ice, compression, and elevation. Okay, let's do one more question. Epiphyseal plate fractures in children may repair very rapidly, disrupt the growth of the bones, only happen during infancy, or do not develop until adolescence. Yes. So if it's going through the epiphyseal plate, the fracture is, so Salter-Harris, remember reading about that, Salter-Harris fractures? Maybe you guys haven't read for this week yet, but that's what your reading is for this week. These are fractures around the growth plates. Okay, so the epiphyseal plate is another term for growth plate. Okay, so if there's fractures in these areas, then it's not unlikely that these kids can have kind of delayed growth in those bones that they fractured. Okay. All right. Any questions, concerns, thoughts? No?
No.
All righty. Have a good rest of your holiday. Thanks for joining me.
Thank you, Professor.
Yep. See you later.